So my topic today is the portal vein thrombosis in cirrhosis, controversies and update. So by definition, simple definition, it means just clot in the portal vein or one of its main branches with or without extension into the mesenteric veins. Now, traditionally, it's been also classified as acute and chronic, partial, complete, cirrhotic and non-cirrhotic, and also malignant, non-malignant. Now, if you say malignant, it strictly doesn't come under the category of portal vein thrombosis, because malignant generally means it's an invasion of the tumor by itself. If you look at the more complex definition, then the one by Sarin et al. Puts into how the portal vein presents, what are the signs which occurs, and also the background. So this is more of a complex definition and a complete definition of portal vein thrombosis. You also then have the anatomical functional classification, which was published by Prashant and the Paul Bruce group. But this is, again, more to do with the transplant setting. Now, moving on to the topic of portal vein thrombosis and cirrhosis, it's generally agreed that the portal vein thrombosis and cirrhosis is about 7 times more than the general population. Now, it is assumed that the general population incidence is about 1%, and that's based on postmortem studies from Sweden. Now, again, if you believe that the portal vein thrombosis has occurred before the death process, then it's 1%. But as you know, during the process of death, if the portal vein slows down, if the thrombus formation is there, and it is related to that may not be relevant. But anyway, that's just taken as a standard. Again, what is very clear is portal vein thrombosis increase as the degree of liver failure increases, and is more so when you have an HCC. So it can be anything from about 6-8% to 25%, and higher in HCC patients. And a meta-analysis have shown that if you follow portal vein thrombosis for longer duration, then you get more incidence. So basically, it says that as the disease progresses, you have more incidence. And in Italian prospective study, this is only involving Caucasian patients, I've shown the annual incidence for about 6% and the spot incidence about 17%. What this also showed, interestingly, is a previous portal vein thrombosis is one of the biggest risk factors for formation of portal vein thrombosis. What is the stuck? So what we'll do is we will go through all these topics related to the portal vein. Now, we will see what is obviously known to us and also look at what are the controversies surrounding the topics. We will stop. We need to. Right, okay. Right, so moving on to the pathogenesis first. The thrombosis in any vein goes by the virtuous triad. So that is a combination of stasis, hypercoagulability, or vessel injury in general. And when we talk about liver cirrhosis, we obviously know that the liver architecture is disturbed. The portal flow thus decreases because of the resistance. And once the portal flow decreases, there is stasis and then formation of clots. What has been shown in studies and which has been multiplicated in many other studies as well, is when the portal flow decreases to less than 15 centimeters per second, then there's a high chance of forming thrombus. Again, when you have liver cirrhosis, portal vein flow slows down. There's also spontaneous portosystemic shunts which form. And when you have loss of flow in the shunt, then the flow in the portal vein decreases, again leading on to the thrombus. So the Japanese group, which performed the study mainly in the Hep C population, have told us that if you have a shunt which has got a flow of more than 400 ml per minute or more than 10 centimeters per second, due to Steele phenomenon, the portal vein flow decreases and that leads to the formation of thrombus. Now again, when you're talking about slowing of blood in the portal vein, you have to talk about the beta blockers, because beta blockers are extensively used both in the primary and secondary setting, and beta blockers do decrease the blood flow in the portal vein. If you look at the Italian study, there is no correlation between portal vein and beta blockers, but it did show correlation with worsening liver disease, HCC, and other things I've shown here. The other two European studies did not show did show a relevance to portal vein and use of beta blockers. So on the whole, we are still not sure if portal vein thrombosis is related to beta blockers, but we need more study, primarily this as an endpoint and usage of beta blockers in cirrhotic patients. So practically speaking, if you have a patient who's on beta blockers who has portal vein thrombosis and present variceal bleed, you still continue the beta blockers because that's when the patient needs it more because of increasing portal hypertension. The other topic is a little more complex. So normally the liver produces both the anticoagulants and the procoagulants. The liver normally produces these factors more than double of what a normal body needs. So when you have early stage of cirrhosis, although these factors come down, they both come down to a level where still you have the equilibrium, but there's a shift in equilibrium. So you still don't bleed. If at all, it tends to overcompensate and goes more towards the coagulative side, which is the thrombotic side, rather than the hemorrhagic side. So for example, if the platelets come down because of cirrhosis, the von Willebrand factor activity both quantitatively and qualitatively increase. And also the enzymes which cleave the von Willebrand factor decreases in the serum. So it's a combination of the factors which keeps the equilibrium, and it definitely holds true for the early stages, but on late stages, when the patient has got worsening liver failure, acute on chronic liver failure, sepsis, multi-organ dysfunction, renal failure, then this doesn't hold true. Then the patient becomes coagulopathic and bleeds more. So if you look into clinically, the evidence for that, there's a large US inpatient database which tells us that cirrhotic patients under 45 years of age are more likely to experience non-PT, non-PVT related venous thrombosis. And if you again look at patients who develop thrombosis, there is no relation between INR. So in other words, if you have a patient who has got high INR, it does not mean that the patient is not going to get a thrombotic episode. But this venous thrombosis and portal vein thrombosis is more related to the child 2 score, which denotes overall worsening liver failure. Again, the third component of the virtuous triad is the vessel wall injury. It is well known that endotoxemia is a marker of thrombogeneration, and endotoxemia happens in patients with liver cirrhosis. But again, if you look into prospective studies looking into cirrhotic patient endotoxemia, and if you follow them up, there's no increase instead of portal vein thrombosis. So although endotoxemia is known to produce thrombin generation, we do not see that in cirrhotic patients. If you talk about the other way in which vessel wall can be injured, that's when you start treating the varices both by sclerotherapy and banding. If you look at that first study, so these patients are followed up after sclerotherapy. The incidence of portal vein thrombosis in the study was 16, with the follow-up of 16 months, it was about 16%. But again, if you look at these patients, 70% of them had concomitant thrombophilic conditions. So you don't know whether to attribute this to the thrombophilic condition or to the procedure. The other study did not show any evidence. So at present, we still don't have enough literature on whether sclerotherapy, both banding and injecting, predisposes to portal vein thrombosis or not. What is very clear is if you perform splenectomy in a cirrhotic patient, there's a 10-fold increase in the incidence of PVT. This is irrespective of the child status. But obviously, splenectomy in cirrhotic patients are not commonly performed now. It used to be performed maybe a few decades ago, but that's a very strong risk factor for formation of portal vein thrombosis. Now, can we predict portal vein thrombosis formation? In earlier studies, there were some links towards D-dimer, protein C, protein S, but not really proven and not really shown in any major studies. Sarin and Patrick Ahmed with the French group, they came up with some criteria. So that's a criteria which is there. So if you have two major criteria, one major, two minor, or four minor criteria, then you have high probability of developing thrombus or high probability of a PVT presenting in a cirrhotic patient. This again, I have to say, has not been really shown in any prospective study. So there is more information needed on this before we can use this in clinical practice. Diagnosis is something which we're all familiar about. Most of them are incidental. Sometimes they do present with abdominal symptoms and symptoms of liver decompensation, in which case you do the imaging. And then once you do the imaging, before you start treatment, an upper GI endoscopy to look for the varices is a must. If you're looking about how this progress and what's the natural cause, most of this PVT are asymptomatic and most of them show spontaneous resolution or regression. Very few of them progress, and when they progress, they tend to get symptomatic. Again, the asymptomatic in them is more common than the symptomatic part. Now, all thrombus formation in the portal vein, it should start acute and then goes on to become a chronic phase. And by definition, if you see a cavernous formation in imaging, it's taken as chronic. But the problem here is you can have cavernous formation as early as 6 days. So yes, if you don't have cavernous formation, if you have cavernous formation, yes, it can be chronic, but then it can be a short period as well. Again, if you look into risk factors of why the portal vein thrombosis resolution occurs, there's no definite risk factors known. But the Japanese group has again shown us that if you look at the degree of portal vein thrombosis and the associated contrast uptake, so if you have a thrombus which takes contrast cystic, there's a fresh thrombus internally, then there is a more chance if you treat them, then they are likely to resolve. What about the clinical impact? Now, just common sense would tell us if you have a portal vein thrombosis, it causes more portal hypertension and it's got more variceal bleeding. The first study, which is published in 2003, tells us that when you have portal vein thrombosis variceal bleeding, then there's a threefold higher risk of failure to control the variceal bleed. But that has not shown any mortality difference. The study done recently have shown that yes, it's true. It just takes a longer time to control the esophageal varices by 8 days, but that does not result in treatment failure. So it probably needs more treatment episodes, but not treatment failure and not no increase in mortality. What about portal vein thrombosis and liver decompensation? The large meta-analysis have shown that there is increase in mortality and ascites, but there's no difference in GI bleeding or encephalopathy. A prospective study done in more than 1,000 patients have shown the opposite. There's no change in mortality or decompensation. And a systematic review recently have shown that because of the heterogeneous data and the difference in follow-up period between studies, it's difficult to draw a conclusion. So although it looks obvious that you have a portal vein thrombus, you can have high portal hypertension and have worsening of the liver status, there is no data as such to say that this happens. What about the progression of the PVT or the regression? Again, studies have shown that it doesn't impact the survival. What is important is only the CTP score at the time of diagnosis is important. So what is generally thought about PVT and cirrhosis is PVT is not something which occurs on top of cirrhosis, but they represent an independent synergistic phenomenon, both of which are because of the same process of worsening of the liver. Now, this again has been shown by the French group who used low molecular weight heparin, and that prevents both portal vein thrombosis in the follow-up studies and also liver decompensation. This again is going by the hypothesis that microcirculation thrombotic episodes are the reason for the liver to decompensate, and with the same process, you have portal vein thrombosis as well. Again, this is again the French group which has shown this. Other studies doing similar protocols have not really shown us this data. In the transplant setting, we do come across portal vein thrombosis quite often. It can be up to about 25%, unrecognized up to 0.5% till the time of workup. Now, studies have shown us in the early stage and the logic as well that when this occurs, you have more technical complications, more post-operative time, increased blood products needed during the surgery and after that, increased ICU and hospital stay. But look at a recent prospective study which has gone till 2014. It is shown that only severe grades of portal vein thrombosis affected outcome, mostly in the short term, which is the 30-day mortality, and long term, it did not affect. And the meta-analysis showed us very clearly that the portal vein thrombosis type and the surgical technique are important in the post-transplant outcome. So if the portal vein thrombosis is extensive going into the distal superior mesenteric vein, then there is decreased 1 year survival. And most importantly, if the surgeon is able to perform an end-to-end portal anastomosis, that is anatomical anastomosis, the survival is same regardless of the degree of PVT. So this is very important clinically, that if you have a patient with portal vein thrombosis large enough for extending the mesenteric veins, it's better for the patient to get transplanted in a high volume center with experienced surgeons, because if they can perform an end-to-end portal vein anastomosis, this makes the difference for the patient. What about monitoring and managing these patients? If you have a patient waiting for liver transplant, the American guidelines, again, it's not the guidelines by studies, it's more of expert opinion. They say that performing 3-monthly ultrasound in this patient may be reasonable, because if you can detect portal vein thrombosis in the patient, anticoagulate them, then you prevent complications down the line. And the aim of this anticoagulation is to allow the end-to-end anastomosis of the portal vein. Anticoagulation does achieve good recannulation rate in this patient, about 40%, and it has to be continued till the time of transplant, because if we stop early, then the recurrence rate is quite high. For patients who are not on the transplant list, a routine 6-monthly ultrasound, which we do for screening or HEC, is adequate. And the EASL guidelines recommends 3 to 6 months of anticoagulation, but also recommends a few months more after the recannulation is achieved. And if you have SME thrombus or intestinal infarction, then it's a long-term, lifelong anticoagulation. There are concerns about bleeding in these patients, spontaneous recannulation, and also the studies which have been really small retrospective data. But on the whole, anticoagulation is recommended. Now, before anticoagulation in any of this group of patients, you need to perform an OGD, look for the varices, make sure they are sorted out before starting them on anticoagulation. So coming on to the anticoagulation groups of drugs, so you have the traditional warfarin, which acts on the clotting factors. Then you have the low molecular weight heparin, which has indirect action on factor 10A. Then the new anticoagulants, which are the rivaroxaban, apixaban, edoxaban, prednisolone, and the dabigatran, which has got direct action on the 10A and the thrombin formation. So if you look into the traditional low molecular weight heparin and the vitamin K analogs and VKAs, the like warfarins, you have large studies, you have meta-analysis, and you have multiple small studies. On the whole, you have acceptable minor bleeding in these trials. The portal vein cannulation is pretty decent, and it also slows down the progression of clot. So these are well used, it's been used for a pretty long time, well accepted all over the place. The newer ones on the block are the direct acting anticoagulants, and there are 5 at the moment. 4 of them are direct inhibitor of factor 10A, and dabigatran inhibits the thrombin formation. As you can see, except the betrizaban, everything has got a hepatic metabolism, and the drug level does not get much affected in the child's A, but child's B, it gets affected. There's not much data on child C, but you can expect that in child C, it is not going to be very useful. So just put it together. What we know is in child's B, the area under the curve concentration is significantly affected in rivaroxaban 2.27 times, edoxaban quite high at 4.8, and dabigatran as well. The AUC of apixaban, that's we're talking about a 5 milligram dose, not a 10 milligram dose. The AUC of apixaban is not much affected in child's B status. So child's C, most of them is okay. Child's B status, only apixaban seems to be safe. Again, there are multiple trials on these newer drugs, and these have been used both in portal vein thrombosis and cirrhotic patients, and also on other indications like atrial fibrillations. This was for both treatment and for prophylaxis. So what these multiple studies have shown is, I'll come to the conclusion later, but also what we know is there is no direct comparison between the newer anticoagulants, and the vitamin K or the low molecular weight heparin. But a Japanese study has got a historical comparison from that institute. So what they have done is they usually give 2 weeks of low molecular weight heparin to the PVT patients. And the patients who were diagnosed prior to 2014 received warfarin, which is about 30 of them. The other set of patients received edoxaban, which is about 20 of them, and these patients were followed for about 6 months. What is significant in their study was patients receiving edoxaban compared to warfarin achieved much higher resolution of the portal vein thrombus, 70 to 20%. And also the progression was much slower in the edoxaban group. The bleeding events are small, but statistically, because it was not powered, you cannot draw major conclusions. But it does kind of tells us that the newer anticoagulants are probably more effective than the warfarin and the low molecular weight ones. Now, there are also some concerns with the direct acting anticoagulants, although a meta-analysis has shown that the rate of drug injury is not significant. The real world data and day-to-day practice says that you can sometimes get problems with the direct acting anticoagulants. Rivaroxaban is probably the worst of the culprit. All others have been shown to have some drug-induced liver injury. But on the whole, if you want to choose, then apaxaban seems to be the safer option as far as the liver injury goes. There are also concerns about thrombocytopenia and bleeding with the direct-acting anticoagulants. Again, this is not through literature, but expert opinion says that if less than 50, be cautious, and between 50 and 80, you can still give, but you have to watch out for bleeding. If it's around the 1 lakh mark, then it's generally safer. With pregnancy and lactation, these can't be used, the newer drugs. With pregnancy, it's probably never going to be used because you have a safer option of low molecular weight heparin, which does not cross the placenta. Just to compare these drugs, you have the direct acting as a group, low molecular weight heparin, and the warfarin, 3 groups. The direct acting, the experience is much smaller than the other 2. It looks much more efficacious than the other 2 groups. The washout period is only about a couple of days. The route of administration oral, which is much easier. There seems to be hepatotoxicity, especially as the liver worsens. With low molecular weight heparin, there's a good safety record. Washout period is about 2 to 3 days. The antidote protamine is available, but I'm really not sure about the potency of that and the ways to monitor that. Injection is obviously the route. Hepatotoxicity is rare in these cases. Warfarin, again, it is well documented. It's got a long track record. It's got a washout period of 5 to 7 days. Antidote is very cheap, easily available, easily administered. It's again oral, but this just needs a long-term monitoring. Again, just putting everything together and mainly looking at the reversal. Reversing a warfarin patient is much easier. So you need a little bit of vitamin K, a few milligrams. If you probably give about 10 milligrams, that is completely saturated. You can give plasma if bleeding is an issue, IRL is very much prolonged. And if a volume is problem because of plasma, you can use the plasma, concentrates, the clotting concentrates, which is generally costly and it's not easily available, but yes, it can be got in emergency. It's usually about 2.5 lakhs per patient. The newer drugs, we have the Praxman, which has been there for a long time, but that's only for the dabigatran. It is both FDA and NICE approved and costs about, again, 2.5 lakhs here. The other antidote is not that easily available and it's a bit more costly. I'm not sure about the cost and availability of these in India at the moment. So on the whole, if you look at the direct acting anticoagulants, it's reasonable to use this as an alternative in patients with compensated cirrhosis without severe thrombocytopenia, both for prophylaxis and for treatment. You cannot use it in child C because there is no data. Although there's some data in child B, I know most of the hepatologists and the transplanters don't use it. So essentially, it's a child's A usage, and if you really want to pick up the one of these agents, apaxaban seems to be the treatment of choice. Now, finish off with a couple of cases here. We had a patient who was listed for transplant, had extensive portal vein thrombosis. This happened a few months ago in middle of this corona crisis. Ideally, we should have started him on warfarin, but then we choose fragment because one, it will be difficult to monitor warfarin in this patient. He had to come to the hospital every 2 days to get the INR check, so that was not possible. We have to give him fragment, but you can clearly see that the letter from the liver transplant unit prefers anticoagulation warfarin because one, you cannot use the direct acting because of the decompensated stages, and also reversal when you call them for a liver transplant middle of the night when they get a cadaver is much easier and much more efficient with warfarin and the antidotes compared to other drugs. So in a transplant setting, decompensated patient, the chance of calling the middle of the night is high. You can't really plan a DDLT, especially warfarin is the choice. Having said that, the direct acting anticoagulants are being used more than warfarin for other indications. And if you look at patients who are well compensated, and if you are to use them even for other indications, atrial fibrillation, apixaban is the treatment of choice because one, you don't have to inject, you don't have to monitor, and as long as the patient remains in child say, it's probably safe to use. So with that, I will finish my presentations, and I don't know the questions whether it's now or to be taken later.
Thank you, Dr. Olith, for that comprehensive review. Probably the pressing question in every transplant surgeon's mind about where the DOACs really sit in the context of a transplant patient. So the challenge, of course, is slightly different in a DDLT and an LDLT program because in a DDLT program, we have unpredictability and about how do you plan a DOAC and when do you actually change to warfarin. That is one sort of issue that is very difficult to predict.
Yeah.
So there are two questions which I'll probably just ask you right now.
Yeah.
The first question is from Dr. Sedu Babu. One is, what is the impact of PVT on HVPG measurement?
Yeah.
And the second one, the same as that, is the occurrence of PVT more after a variceal bleed? These are from Dr. Sedu Babu.
Yeah. So theoretically, again, if you kind of think logically, the pressure increases and HVPG also increases. But what is not shown is that pressure increase has not shown a difference in mortality for sure, and there is no major studies to prove that. Similarly, if you intervene a varices with both injecting the sclerosants and banding, it does not cause more PVT. Now, what we are not sure at this stage is if you inject the glue, sometimes which we do in esophageal varices, that we are not sure because the data is not there. The number of patients whom we inject glue for esophageal varices are very limited, and that data is not there. But what we also know that is you can have these glues anywhere in the body after some time. So you inject a glue and suddenly you find that the kidneys are infarcted, or sometimes you get a PFO and you get a glue in the brain. So we had a patient here about year ago. I was not here, but one of my colleagues were dealing with it. So this guy has basically developed a fit after glue injection, and most of the glue which was injected in the virus is sitting in the brain. But there is no evidence from the injecting drugs, sclerotherapy and banding, to say that portal vein thrombosis increases after that.
Okay. The second question is from Prashant Bhangi, which is, I think we've answered this in part. What, according to you, are the patient and the risk factors that determine the utility and feasibility of using anticoagulation in higher grades of PVT who are on the waiting list or complex PVT?
Yeah. So
yeah.
If you are talking about a transplant patient,
we're talking about a pre-transplant patient, not a waiting list.
Yeah. So obviously he's going to come for transplant. So
yeah.
you are going to get him for the transplant, one in a DDLT setting or LDL setting. So in a DDLT setting, it could be middle of the night. So if you have that scenario, you need to have an agent which can be reliably reversed. And if you are warfarin, then you have vitamin K, FFP, and the clotting factors, which are well used, easily available, and also you have something to monitor. So you have an high INR, give AFB, INR decreases, the surgeon is happy to take the patient. So that is easy, and also it can be used for decompensated cirrhosis, which most patients are.
Yeah.
Obviously, that's the reason why they have transplant. If you are going to use low molecular weight heparin, again, the reversal is not very clear in that, because you can use protamine, but then what do you monitor? Is the surgeon ready to take a patient just giving after protamine without actually knowing what the status is? That is something which is not been extensively studied. So again, low molecular weight heparin may not be suitable in the case. The direct acting, again, you're probably ruling it out in most of the patients because you can't use it for C and B anyway. So if at all you use, you might use it for a child, say maybe with HCC, with a blunt thrombus. But that again, if you're going to bring him middle of the night for DDLT, that's going to be difficult to reverse. Again, with the experience what we have, availability of the antidotes. So the best would be warfarin for these patients. If you're talking about LDLT setting where you have the option of getting in the patients a few days earlier, admitting them, stopping the drugs, monitoring, then any of these three should be fine. But in a DDLT setting, I think it has to be warfarin. And in LDLT setting, you can use anything as long as for the direct anticoagulants is not a decompensated patient.
Sure. I think you answered Dr. Rajshekhar's question already about the heparin. You just discussed that. Sandeep had asked a question about the use of DOAC in the post-LT setting. Any specific comments about that or any evidence about that?
No, I don't think there's any evidence for use of DOAC in the post-transplant setting as of now.
Sure. And Pawan had asked, how do you measure target INR in a patient who's already got a deranged INR?
So if you're talking about warfarin, then the pre-warfarin INR is important. Now, if you think there's some cholestasis, some nutrition element of the INR, you can always give a shot of vitamin D to see what is correctable, get the baseline INR. So if the INR is stage 2 to start with, then you give warfarin and probably get it from 2.5 to 3. But then it's important to monitor that because one, the warfarin itself can cause problems, and also the patients can deteriorate.
Sure.
They can have other issues, have INR. So it's important to monitor them and then adjust the warfarin accordingly.
Sure.
So generally 2 to 3 in these patients.
Sure. And Adarsh has asked a question about when do you start anticoagulation after a variceal bleed or an EVL?
So you have to make sure these varices are completely decompressed. And it's also important that when you have a look, there are no large post-banding ulcers, because we do see post-banding ulcers sometimes which are really huge and troublesome, and they take longer time to heal than the actual varices. So you need to make sure, one, they're decompressed, the variceal banding ulcers are not significant. You can probably give them a little bit of PPI. I don't know what difference it makes. There's no literature for that, but you can probably give a little bit of PPI cover. And then if you're convinced that the pressure is low, the varices look decompressed, then you can start the anticoagulation.
So the only thing, Vivek might want to chip in here as well. I think as a surgical perspective, just operationally, we are much more comfortable operating on a person who's been on Clexane or a low molecular heparin than probably a DOAC. Because the same challenges would apply. But I think that's what my thinking would be. What do you think, Vivek?
I think perfect, because reversibility is the major issue with us. We want it to be reversible in a kind of brink of time. So that's the major thing. And secondly, I think when the patient is already listed for LDLT, there's in my mind there's hardly any worry. In fact, rather than a partial thrombosis, I will prefer more of a complete thrombosis, because it makes my life simple to do thromboendovenectomy.
Sure.
So yeah.
Okay.
Yeah. The other thing is, most of the studies which have have shown is in probably the pre-TEG era. So again, if you have a patient who is on heparin and you want to reverse it, you can use protamine. But then if you have a TEG measurement pre and post, and there's improvement and the surgeon is happy with that, I think you should be still able to go ahead. But again, there's not much of literature on that, because TEG and ROTEG are something all newer, mentions.
That's a very good point, because nowadays I think in the future we'll be guided more by tech than by a baseline INR. So that's a good point. Thank you so much, Dr. Ole. I think we'll just stop here now in interest of time, and we'll move on to the next talk. Thank you. That was a very wonderful exposition.
Thanks, sir.